first asked him if he'd be a part of this, I was told that John has just had an injury and he may not be the poster child anymore, and at least while he's recovering. So I said, well, great, this is your opportunity to be honest, that we all get these injuries. Sometimes when we get older, it takes a little bit longer to recover. But so John joined us, even though he is recovering from an injury. So tell us, has your recovery time from injuries changed from, say, 50 years ago or 20 years ago?
No, actually, for the people that are physicians here, they are probably familiar with it because I'm doing fairly heavy workouts for getting ready for competition and building muscle. I have had injuries on my rotator cuff and on both arms actually, and so I've kind of backed off a little bit from the heavy competition, but I'm pretty much in recovery now, although my rotator cuffs are torn. I talked to one of the physicians at one point about 5-6 years ago. I had a replacement on my knee replacement. The amazing for those of you that have had it and those of you that may at some point may have to get knee replacements. It never slowed me down really from competing. In fact, sometimes I was doing heavy leg work at the gym and looking at my knees and I thought this thing is gonna bust. But no, so it never bothered me. So with the shoulder, rotator cuff, a little bit more complex, very difficult. They advised against surgery, and so there is some damage, but I still have good muscle tone, but now I'm going to go back to my normal routine of going to the gym. And the recovery is classically slow with rotator cuffs, apparently.
Okay, John, well that's, you're still an inspiration no matter how you look at it, so thank you for sharing that part of your story. And I think you've woven the interaction and the diet and nutrition into your talk. I mean, if the only thing one does is go to the gym, I guess they're interacting then, hey?
Be active, so yeah.
Okay, great. So we'll go on to our next person here. Now, our next person and he's been the most recent to come to this group. I mean, I just found out about him a week or 10 days ago, but he's a recent graduate, so a fairly new doctor. It serves the Indigenous communities and rural and remote communities. So I want to welcome Todd Alec. And Todd, so tell us a little bit about what you do and just how you think the whole avoid thing will fit in with the Indigenous communities.
So thank you for inviting me, and it's quite incredible stories. It reminds me that the artist Tom Petty, when he says, "You never slow down, you never get old," and that really kind of emphasizes on that. And I wouldn't want to lift with you, by the way. So, yeah, I'm Todd Alec. I'm originally from Nakasley, and I just finished my training to become a family doctor. So I have the opportunity to go back home. So I got the opportunity to go back home, so I'm working back in Nakasley a week of the month, and also I go to Yekuchi and Takla, which are some rural communities, to do some outreach work with the Carson County Family Services. So I get to, and then do a bit of hospice work here in town, and yeah, so I get to see a little bit of different care of how care is provided in a bigger urban center. And when we discharge people, the occupational therapist will actually go to their house and make sure that all the supports are in place before they go home. And and then also I go to places where they're actually discharged here, but then they have to drive 5 hours back home, and we don't have any occupational therapists, but we do have a physiotherapist that's there occasionally. So the services are quite different, and we're also trying to figure out how to provide better care for our elders and see what kind of works. So it's kind of a neat opportunity to see, and then also try to work on better approaches. With this avoid is kind of our fundamental things that we try to do. We try to get our people active. Obviously, access to some of the things that we can is a little bit lacking in some of our rural communities. So we have to kind of work with some community partners and to try to open up the gym and try to keep them busy with some of our programs. Vaccinations, we really try to advocate for our vaccinations. We do have people who have flu clinics. I think First Nation Health Authority now is starting to look at funding Shingrix. I think they do in certain situations, but there might be some exclusions. So we usually work with our partners in the band, and they have actually been covering for some of the vaccinations for that. And then we look at Prevnar in some of our more complicated patients and move them to Pneumovax if they're indicated. Interaction is a big thing. We try to make a lot of social events, and you know, I hear a lot of talks about isolation, and so try to have some outreach services so that they can, you know, feel like they're team people. But you know, it is a big thing that we're actually having a problem with right now. Because we just don't have that access, and so a lot of our communities have very limited support outreach. So there's probably a lot of elders actually at risk that we don't know of. When I'm in Nat Cassidy, it's nice we have this big network of nurses. So we have some community nurses. We also have home and community care nurses and support staff that actually go into the communities to help with the bathing, help out with cleaning up their house, and they come triage and come to my office and say, hey, this elder is actually not doing so well. Can you go see them? And you know, working in the way that I have, I can spend an hour and go to their place, have some tea with them, and chat and see how we can optimize things. And then when things are getting a little bit difficult, we have some great geriatricians that I got to train here and refer to them to see if they can help out looking at some of their medications to help support that. So it's great that we have some of those things, but some places we don't have nothing, so we need to kind of figure out how to better do that. So, and for the diet and nutrition, you know, we as doctors, we always say, you know, you gotta improve it, you gotta exercise more, and you gotta eat more fruits and vegetables and do these things, and sometimes we forget about where they're actually coming from, where people actually have limited resources and they can barely afford to pay for food, so they're just getting whatever's cheapest. Up in Takla, they have some better food sources now that they can get some fruits and vegetables, but it's not really readily available all the time. So we kind of have to work with what we're going from and trying to see how we can do a better job to provide better care. And so I think we just always have to reminder of that lecture, and we say, oh, you got to do these things, but then also remember where they're coming from and try to work with them to try to better their stuff.
Great information, Todd. And, you know, I just want to touch a little bit on that whole, we hear a lot about cultural safety these days. And, you know, I'm just wondering if maybe you can expand on that. I've heard many meanings of the term elder. Some is as we are getting older. Others are people of the First Nations communities sharing their wisdom. Older people of the First Nations community sharing their wisdom as being known as an elder. And, you know, and again, a lot of these things around cultural safety. Can you expand a little bit on that?
Yeah. So elders, you know, we kind of consider like our wisdom keepers and people that kind of been there and have a lot of knowledge to share. So we really put them up in high regards because they give us a lot of that knowledge that we have had for many you know, generations. So we really look up to them to be able to get some guidance on things. And so in that regards, I think a lot of our people typically don't go in homes, and a lot of people are caring for their own community members. And so you know, we don't see as many ALC assessments of our people, and a lot of people will really look in a community perspective to how to help them out. So I think it's just kind of paying it forward because of all the things that they've done and what also they have to offer. So we really try to keep them in high regard. And you were talking a bit about cultural safety and competency, and I think the biggest thing is about relationship building. And even as an Indigenous doctor starting to go do this outreach work, like no one really showed up, and I was like, what's going on here? Like, and you know, it was slow at first, and then it started picking up once people starting to know you, understanding you, and just figuring out how to work with our people. And so I think the biggest thing, and Dr. Dave Snadden was talking a bit, is the biggest thing people really look at is time. And so if we could spend that time to get an understanding of where they're coming from and to get to know a bit better about them. and then just kind of figuring out what some of the limitations are. So sometimes there is a bit of a language barrier, or if or else they might have just a different perception of how they want to provide care. And just figuring out that so that you can really work with them to see what their kind of objectives are, and so that you can be in line with them is just the biggest thing. And, you know, getting some background history and learning a little bit about the local people too does wonders. So even just saying howdy and say hi and carrier is kind of a great thing to see. You know, working with some of our, we have quite a bit of Indigenous physicians now out there, so, you know, we're always happy to work with some of our other colleagues to try to work on how to indigenize programs now, or just to have it looking at an Indigenous lens to try to provide better care for our people.
Thanks, and you know, it's just a really interesting thing to, you know, diversity is a really important thing, and, you know, our Indigenous population is very alive and well in our northern part of BC. So, you know, I really admire the holistic perspective, the medicine wheel, all of that sort of thing. And so we like to hear about that, and I just want to say a couple words about the Canadian Frailty Network. I mean, if anybody has ideas about how to further collaborate or any initiatives and that sort of thing, you can find John here is a member, he's a scientific director, part of the Canadian Frailty Network. Tom, who introduced us, is part of that. There's a number of different people here, so if anybody has any ideas that they might like to run by the people through the Canadian Frailty, they've got a website. They talk about community partnerships on there. You know, when I first reached out to them, they were very open to hearing about different things. They just had their conference just last month over in Toronto, and rolling out the Avoid campaign here. We did it in the Zoomer studios in Toronto, and this is where we got to actually meet some people. So as Tom said earlier, Zoomer means boomer with zip. And, you know, so it's about moving forward, and it's about creating a new way of doing things. And I just wanted to say a little bit about our experience last night. And there's a few people in this room that were in my car with me, and I'm talking about starting conversations, and I'm all for starting conversations that need to be started after the event that we were at last night. And just going off on a little sidetrack here, but there was a doctor in my vehicle that is in this room, and there's another lady as well. And so I was talking about, you know, just that I felt upset about this. I even asked them if they wanted to leave partway through the event, because, you know, I mean, I really felt that, you know, there was no talk about really prevention. They were just, you know, showing people falling down and, you know, being led by devices and that sort of thing. So I was feeling kind of upset. So I was talking to these people in the car, and some of the conversations just in my car that got started. The one lady, she talked about, well, you know, she thinks that, you know, there might be some social denial that, you know, this sedentary lifestyle that we live, you know, we need to have a little more awareness. And the doctor that was in the car, he suggested that, well, you know, maybe some coaches, maybe they could help. So, I mean, we've got enough people in this room that are connected to the education system. Maybe personal trainers and fitness instructors and that sort of thing can get fitted with a Avoid certification. I don't know. That's just part of starting a conversation. But, you know, if anybody has any ideas that they may want to run by the Canadian Frailty Network, Amy, who is at the front desk, or John, or any number of people here can probably help you out with maybe inspiring some new ideas. I really love it when BC can be part of those change makers. We've got just a short little bit of time left. Want to do a little bit of a roundtable of final thoughts. So with that, Joyce, did you have any final thoughts about Avoid and activity part that maybe you missed earlier?
I think that John said it all, right? He's a hard act to follow, because I think it is a question of keep moving, keep going. I was also struck by you, Rita, and John, by their attitude. I think there is a lot of research about attitude and having a positive attitude and how it makes a difference. But to come back to the question of activity, I don't know that all of us are going to become bodybuilders. I don't know. I'm not. I'm just saying. But I think that looking for ways of being active all the time, every day. You know, walking to the post office, taking the stairs instead of the elevator is a really nice way to to keep people active. I think the other element that I just like to finish with is to say that I think we as professionals, kinesiologists, fitness professionals, social workers, whatever, have to actually put a little bit more thought into how we can make these kind of programs that have a physical activity component to them, how we can make them fun, how we can make them affordable, how we can make them more accessible to people. Because, I know that as you asked me way back at the beginning, how are the programs for older adults different than for younger people? And I think in terms of my own classes, the social interaction that happens is every bit as important. It's what brings people to my fitness classes. For two reasons. One is because it's fun and there's a lovely community there. But the second thing is that everybody in the room is going to ask, hey, Todd, why weren't you there last week? Where were you? How come you didn't show up? So there's this pressure that develops. We talk about social interaction, and physical fitness is a very good way. Structured physical fitness in community is a very good way of achieving that. But I think we have to make sure that what we're presenting, is appropriate for people as we get older, and as I said, is accessible and fun, affordable too.
Thanks. Fun and affordable, that's another A, affordable. Thanks, Joyce. Maureen, any final thoughts from you on vaccines and optimization of meds?
I think it really boils down to people being responsible for their own health care and making sure that they have those conversations with the people that they need to support them within that journey. We're all on our own journey through life, whether it be health or fitness or activity or interactions, and we need to make sure that we take those steps to be responsible and interacting with our healthcare team to fulfill that.
Thanks so much, Maureen. And so Maureen is, what I've always found about Maureen is she's very open to different kind of ideas. I've known her since back 10 years ago when we first did some of our very first New Vision of Aging, and when we were both Patient Voices Network, we attended the first conference, and I think it was here in the Civic Center. And when we asked the people, the representative from Northern Health, what it was that we were doing, and she says, well, it's kind of like building an airplane in mid-flight. And I just thought, let me on that plane. so that's how long I've known Maureen. And
we're both 29.
Yes, we are. Actually, I'm going to be 64 on my next birthday, too. So we start talking about our ages, and just, it feels better to talk about our ages. I mean, we've all had to, do some paradigm shifts, and that topic has come up. And John certainly has had to do paradigm shifts, too. Do you have any final thoughts, John?
Yeah, I like the forum, I like the dialogue, so important, and I think so appropriate, so I compliment you for that. In terms of, I don't want to discourage anybody from going to the gym. Gym can be an intimidating place, but it doesn't have to be. And, I didn't go to the gym. When I first went to the gym, and after my diverticulitis operation, I didn't even know how to sit on the machines. I was overweight. I couldn't do plank. I couldn't do push-ups. I couldn't do anything. So I call myself the accidental bodybuilder. It just happened. And the reason that it happened is because I was doing the right things, and they started to show results. And then before you know it, then people said, oh, you look good. Do I? And because it goes so slowly, and then gradually from there on in, you kind of see it yourself, and you start flexing a little bit, and yeah, this is working. So it was not something that my dream was to be a bodybuilder. No, just the opposite. It was accidental, and then it became a challenge, and then I followed the challenge, and it brought me to the national and international level. That is simply saying that everything is possible. So that do not think because when I started going to the gym, I was 68. And, and do not decide that you cannot participate. Do not decide that you're too old, you don't look good, and all these other things. Think positive. Enjoy it. Life, for me, it's more exciting now than it used to be when I was 20, 30, 40. I enjoy it more. I'm more active, and obviously, I watch my diet. I'm trying to stay fit mentally and physically, and that's what really it is all about.
Thanks, John. And just another note about John too. He on the last New Year's Eve, I think it was, he did the Boogie with the Stars. There was a group I hear, and he was one of the dancers. So that was great. So Todd, any final thoughts from you?
Yeah, I guess just talking about the cultural sensitivity and just really thinking about our biases. And, some of them are ingrained. And, one of my colleagues would say that we're all racist and at a certain extent, and we do have our perceived biases and just really trying to look at those and try to prevent that from sometimes the coming out when you're having those interactions. And another thing even that I've been learning is sometimes we have bad days, like we're on call the whole night, we're on for 24 hours, and the next day you're tired. And just really trying to reset yourself before going to see those patients, and all patients, because sometimes we have those bad interactions just because we're at those kind of days. And then I guess just the second thing is just talking about really just emphasizing is finding out where they're at and people are coming from. When I was an early resident, I prescribed all these medications thinking I'm trying to optimize things and help them out. And then coming back and then I'd say, oh, why didn't you take it? And then it turns out a lot of them couldn't afford it. And these were in urban settings, non-Indigenous people. And I was really shocked to see that and then trying to figure out where people are coming from to see if they can have those supports and trying to utilize the system to the best ability. And then a third one is just trying to just really just working with the patients to try to provide better care, So sometimes, and especially the doctors, we have some very firm thoughts. And I was just reflecting about this thing. And so I saw this lady and she was at the gym and she says, well, I'm not going to my family doctor anymore for my kids. And so I was just there. And so she was having a bad interaction because she decided that she didn't want to vaccinate her children. And so now, think about these like personal judgments of how you're thinking. And we're almost going to get angry about this thing, right? But then it becomes conducive when we start, battling with these interactions that it just got so bad that these kids aren't going to go to their family doctor anymore. So like wellness checkups aren't happening. We can miss developmental milestones. And so I think, we have to figure a way to do it in a manner that's actually approachable, but also to try to not, give them a hard time about these things so that you can try to develop solutions. And hopefully then there won't be more likely to get the vaccinations, but also we might pick up something that their speech delay and that they need some more supports or something like that at an earlier stage. So sometimes our biases can really influence how we're going to affect. So I think we just have to really be cognizant of what's happening. So that's it.
Thanks, Todd. We've just got one last person to sum up anything that we could have missed. But when you're talking about cultural safety there, I just wanted to mention I was at a workshop when I first became aware of the whole cultural safety issue. And it was a First Nations lady was doing this workshop, and she actually brought up the whole boomer culture is a culture of itself. So, it's different than, maybe our parents or our grandparents. So, it's not just about racism, there's ageism, there's, genderism and sexism and the whole bit. I mean, there's, it's being culturally respectful to all kinds of people. And so, that's just some of my final thoughts. And with that, I'm going to ask John Muscaderi to sum us up. We're just about at 4:30, but so you've got about 2 or 3 minutes left. Sum us up for anything that we might have missed.
Sure. So first of all, thank you. It's been a pleasure being part of the panel, and I really appreciate the panelists' discussions. Very insightful. So I think the final thing that I want to address is the concept of frailty and some of the nihilism or the negative connotations associated with the word. The point is that we need to address frailty head on. There's a lot of things that are under our control, and avoid, many of the things on avoid are under our control, are things that we can take personal responsibility for and are preventive. The trick there is to maintain them over a long period of time, because we're not talking about things that are going to make a difference tomorrow. There are elements that are going to make a difference over the long term. And so I think that if we start to think about change the paradigm, or change how we think about aging, how we think about healthy aging, and think about the things that we can control, I think we're all going to be better off. And I really like the idea of a positive attitude, and keep going is halfway, gets you halfway there. Thank you.
Thank you, John. So it's 4:30 now, so you want to finish us up there, Tom?
Let's give them a thanks. I don't think a summary comment is required, and I don't think you could stand it from me anyway, but you do need to be here for 6 o'clock, because we'd love to enjoy your company for dinner, so please feel free. You got an hour and a half, relax, come back, 6 o'clock. See you then. Thanks, everyone. You guys are stars. Thank you.
Thank you, appreciate it.
Thank you very much.